Today's episode is brought to you by DAX Copilot from Microsoft. DAX Copilot is your AI assistant for automating clinical documentation and just being more efficient, reducing administrative burden, all that stuff that makes us feel overwhelmed and burnt out. To learn more about how DAX Copilot can help improve healthcare experiences for both you and your patients, stick around after the episode or visit aka.ms/knockknockhi. That's aka.ms/knockknockhi.
Knock, knock, hi.
Knock, knock, hi. Hello, everybody. Welcome to Knock, Knock, I. With me, your host, Dr. Glockenflecken. Thank you for joining me wherever you are, whatever time it is, on your commute, at home, trying to go to sleep, wanting to listen to eyeball stuff. We're going to get to eyeball stuff, I promise. I'm recording this at night on October 2nd, which just so happens to be my birthday, everyone. I celebrated a birthday today. 39 years old. Not quite 40, 39. I'm 39, my last year of my 30s. And you know what I did today? I worked. That's kind of sad. I worked. I went to work. I did surgeries. I saw patients in clinic because because I'm a physician, right? Why would I take a day off to celebrate my birthday away from work? No, I felt like I needed to see patients. I needed to do so. I've been taking some time off to do my other job of being an internet comedian person. And I was like, I gotta get back to the other job, my first job. It's like they're children. I have to make sure I spend enough time with each of them. And so anyway, that led to me working on my birthday. And it was a good day. It was a great day. You know, I people at work at the surgery center, they were wonderful. They said happy birthday to me, and they tried to sing to me before I ran away from them. And they even got some of the patients that I was doing surgery on. They said happy birthday to me. It was very nice. I got a couple cards. People in clinic all said happy birthday. It was very lovely, very nice. My wife, though, she was like, on your 40th birthday next year, your 40th birthday, you are not working. You're not doing it. You're doing something different. And it was like kind of threatening. Like if I I'm afraid what's going to happen if I don't, if I do decide to work on my birthday. So I'm not going to do it. I'm going to listen to my wonderful wife, Kristen, and I will not be working next year. And then I got home after work and I'm tired because it's an operating day. So it's always a little bit exhausting, but my kids, they made gifts for me. They got me cards. They actually wrote something very nice in the cards. And we had a cake, a strawberry bundt cake. It was great. Awesome. My parents are in town too, so we got to celebrate with them, and just overall, it was great. 39 years old. But you know, birthdays do feel a little bit different to me now, I guess, than they used to. I think part of it is just my medical history. Really, since the cardiac arrest, it's felt really all of 2024. I would say it's felt a little strange. I think it's because every 4 years, so the past 12 years, something has happened. Right, 12 years ago, I had my first bout of testicular cancer. 8 years ago, I had it again in the other testicle. My testicles betrayed me very young in life. And then 4 years ago, I had an out-of-hospital cardiac arrest. I realize some people may be listening to this for the first time or just don't know the story. It's a harrowing tale. If you are close by on our tour, we talk about it on our tour, and we still have some dates open. If you're interested in that, just check out our website on that. But it's an incredible story, and it happened 4 years ago, and so every 4 years, and so this has been like the fourth year, and knock on wood, like knock on all the wood. We live in the Pacific Northwest. I'm about to go and just knock on all the trees. I've been fine this year. But it's like a part of me is just waiting for something to happen. I don't know. It's not logical. Like there's no reason. I'm healthy. But then again, I was healthy before the cancer. I was healthy before the cardiac arrest. So it's like a part of me is just, my brain just can't accept the joy of a birthday. Like what it should be is like happiness that I have reached another birthday, because I'm not supposed to be here. The odds were against me when my heart stopped beating and my wife saved my life. Like I had a much higher chance of not making it. And so you would think that I would be just overjoyed every time I celebrate a birthday, because God, I get to be 39. But I don't know. I want to feel that way, but I don't. I feel it's like this little tiny sliver of dread, which sucks to feel that way on your birthday. There's also happiness. Obviously, I enjoy like being able to be with my family and see my kids and see the gifts they give me and the things they write and the cards and everything, and find they're on their best behavior too on my birthday, which is also big bonus. But I don't know. It's like something's just not quite right. And I think I hope that'll be better next year. Maybe it's just this year, because it's this spooky 4-year thing. So next year's a different year. And maybe I'm past it. We'll see. But next year's 40. I got to do something. I got to do something bigger. And Kristen's always telling me to go somewhere, get friends together and go on a trip somewhere. And I don't know. Maybe I'll do that. Maybe I'll do it. Tell me what I should do, you guys. What should I do for my 40th birthday next year? Because 39's it's done. I got a wonderful day, but 39's in the books. It's not even, who really, honestly, what do you do on a 39th birthday? Like it's the last year of your 30s. But 40, I'm going to follow my wife's advice, or her very like stern talking to, and actually do something and not work. That's the plan. Another thing I did today, by the way, is I recorded a skit. Yeah, I did that. And I didn't only work at my first job. I worked at my second job. I mean, I'm recording this for you all right now, so clearly I can't stop working. But I did a skit, and it was actually very fun. That's the reason I did it. Whenever I decide on a lunch break to record a skit, it's because I have an idea that I have to get out immediately. I'm either so excited about it, or I don't want to lose it, or I just have this like epiphany of creativity that I got to get down. And so I did that today. And this one was about Cigna deciding to sue the federal government, which that idea alone was enough to make me laugh. Like what is Cigna hoping to accomplish by putting their nefarious practices out even more to the world? Because that's what's going to happen if you try to sue the federal government. Everybody's going to learn about what exactly it is you do for your business, Mr. Pharmacy Benefit Manager. Express Scripts, which is Cigna, by the way. Don't get fooled. It's all the same. So anyway, I record that skit, and I do those. I mean, they typically aren't like really well performing skits in terms of like engagement on social media, but those I don't really care. I just want to get it out there because I know people use it to like teach other people about the healthcare system. So that's all that matters to me. I want people to, if you like it, if you want to say, hey, this is what is happening in the world, in this country of ours. Use it however you want. I don't care. Use it. Send it to your favorite insurance salesman. I don't know. So yeah, it was a birthday. I don't want this to be a downer. I don't want you. You guys don't worry about me. Okay. I don't know if that's the way that came across. It's more just like, just thinking about my life, and I'm very happy with where I am. How could I not be? Like I somehow got to combine medicine and comedy into like two careers. I get to do those things. And I have a wonderful family, a very supportive, loving family. It's just complex emotions, you guys. I don't know. It's not, I don't know. Well, what we're going to do is we're going to get into, let's take a break. We're going to come back. And what we're going to do today is we're going to go through some YouTube comments, some great comments recently, some great questions, some follow-up to some of the topics that we addressed the last week or two. So we'll take a break and we'll get into it. All right, we are back. I remember what I was going to say. I was just going to mention, I think about this like every year, is like, what did I want to be 10 years ago? And then 10 years before that, in terms of like my job. And so at 9 years old, I'm 39. So let's start at 9 years old. You know what I wanted to be? I wanted to be an astronaut. That's right. I still joke to Kristen. I tell her that I'm still interested in being like a physician astronaut, just to like kind of make her nervous. Because it like scares her to death, the idea of me going into space, which should. Plus, like, come on, who's going to accept me, Mr. 2-time cancer survivor and cardiac arrest person? Like, come on, they're not, unless it's some kind of charity case. Like, no one's putting me in a spaceship. But yeah, 9 years old, I wanted to go to space. Part of that's because my dad worked at NASA. He was around the aerospace. He was in the NASA community doing aerospace stuff. So I heard a lot about space. And then let's see, 19, I wanted to be a stand-up comedian. I was doing comedy. In Houston, and then also I went up to Texas Tech, in Lubbock. Not a lot of opportunities for stand-up comedy, and eventually I realized, like, you know, I don't know. I liked science. I got the med school bug pretty early on, right around that time, basically the beginning of college, and so I went that route and kissed my comedy career goodbye, or so I thought. 29, ophthalmology all the way. I was really in it. I was setting myself up to apply. Actually, no, at that point, 29, I'm already in ophthalmology. So I've decided comprehensive ophthalmology, no fellowship, private practice. That was my goal. And then 39, here I am. What do I want to be when I grow up? I'm pretty happy where I am now. Doing comedy, doing ophthalmology. Occasionally, I do both. I would like to do a little bit more acting. I think that would be really fun. I've always kind of like a bug. Like, I kind of a little bit want to do a little bit of acting. So, I don't know. We'll see what the next 10 years takes me. But that was the last thing I wanted to say in my whole monologue open about aging. So anyway, let's get to some ophthalmology stuff, shall we? Let's do it. Okay. So the first comment I want to, these are, by the way, these are all coming from my YouTube channel at Glaucomfleckens. That's where you'll find all these Knock Knock Eye episodes and Knock Knock High episodes. Check those out as well. We do interviews and sometimes Kristen and I argue with each other. Not all the time. Sometimes. They're fun though. It's like fun arguing, you know, not the kind of arguing that makes everyone feel really anxious at a dinner party. Okay, so at Corvuscamilis 4117 left a comment about the Kyle Van Noy saga. So I've been talking about a couple episodes ago about Kyle Van Noy, linebacker for the Ravens, who had an orbital fracture on the field. And there was this whole thing about how quickly the ophthalmologist responded and so forth. I'm not going to rehash all of it. But in this comment said, given that they were concerned about him playing again 3 weeks after the orbital fracture. Given that he's a linebacker, getting back into games a scant 3 weeks after the injury strikes me as dangerous. Is it possible to aggravate an orbital fracture if you resume physical activity too soon? That is a great question. So these are the instructions, the things that we give patients about orbital fractures. Number one is that you need to have a dilated eye exam really within a week and a half of the injury. Now, Kyle Van Noy, he got one like 15 minutes later. So that suffices. That's good. The other thing is you can't, we tell people not to blow their nose for 3 weeks. So Kyle Van Noy, I hope he's not blowing his nose out there on the field. So you don't want to blow your nose. And the reason for that is because when you have an orbital fracture, you have a direct connection from your sinuses to your eye. And so if you blow your nose, that's going to increase air pressure in your sinuses and push that air through the fracture into the space around the eye. Now, could you cause any permanent damage? No. Will it be painful? Oh, yeah. That doesn't feel good. You don't want to blow up air through that fracture into the space around the eye. You're going to feel a lot of pressure. It's just not going to feel good. Not going to blind yourself, but it's going to be very uncomfortable. Now, playing professional football 3 weeks after an orbital fracture, can't say anybody's ever asked me that question. At 3 weeks, I would say yes. Now, I'm not sure how quickly he went back to playing or the extent of the fracture. Some orbital fractures can be very small and there might not be a lot of swelling. And so if it's a small fracture that doesn't require surgery, there are certain things that do require surgery with an orbital fracture. If it's a large fracture causing the eye to sink into the fracture or some other malposition of the eye or strabismus where the eyes are misaligned, the patient has double vision. Obviously, if there's muscle entrapment, those are all reasons that you would do a fracture repair where you put an implant like a plate in there to cover the fracture. But often, if it's just like a little medial fracture, if it's a small fracture, not a lot of swelling, you just leave it. Patient's doing fine. 3 weeks? Absolutely. No restrictions. If the patient's recovered just fine. It really depends on the size and extent of the fracture and whether or not a surgery is required to fix it. So, which all things I don't know about this particular situation. Good question. I had a lot of comments recently on the last episode about my discussion of state driving laws. I'm so glad that people agreed with my conclusion that Wisconsin is a scary place to drive. I had several people who agreed with me. They're like, "Oh, yeah, that makes sense. Yeah." People that live in Minnesota and have to go to Wisconsin a lot, they're like, "Oh, there's a clear difference." And the deal is that Wisconsin had very lax driving laws. I can't quite remember. I don't have it in front of me. But it was something like your best seeing eye, you only have to have one eye that sees 20/70, which is pretty poor, and there's like no or very little peripheral field requirements. So Wisconsin, they're boo Wisconsin in terms of driving. Otherwise, the state's great. I love it. It's my in-laws used to live in Madison. We'd go visit them a lot. The cheese aisle at the grocery store, phenomenal. The beer, really good. The football, I have no problem with the Packers. But the state driving laws, they could use some work. Come on, cheeseheads. Get with it. Okay. What else? And someone mentioned that federal standard, this is at Don Barchetti 8026, said federal standards for commercial driver's license are 20/40 vision and no less than 70 degrees of visual field in each eye. That's really good. That's good to know. And so I'm assuming that would be for any like commercial like truck drivers, which I have definitely filled out lots of forms for truck drivers to be able to get their license and maintain their CDLs. So a commercial driver's license, obviously, they should be more stringent than the general public. honestly, the general public really, I don't know, 2040 vision, I think is a really good threshold. It's like I think you need to have 2040 vision in one eye. Now, I don't think it needs to be both eyes, because even with one eye, I think it's actually, if you have one eye that sees 2040 and you have normal visual field in that one eye, I think you're safe to drive. I really do. People might say, what about binocular vision? What about depth perception? You have depth perception with one eye. And we've talked about this on this podcast, there are monocular clues. With one eye, you can tell if a car in front of you, you can tell the distance of that car compared to another car. Or you can tell if one tree is further away than another tree, or a sign is further away than another sign. You can tell distances. You can use what we call monocular clues, difference in size and the speed at which you're arriving towards something. There's ways to do that. So it's kind of a misnomer, not a misnomer, a misconception that you have to have two eyes to have any kind of depth perception. Yeah, it helps. Certainly helps. And your depth perception is better with two eyes, but you do still have depth perception. At Liz Glanz 4966 says, if you want to be terrified of your fellow drivers in a different way, check out how long glasses prescriptions can be written for state by state. Florida allows for up to 5 years. Yeah, that's the thing with some state. I think it's Arizona that has licenses that last for like 20 years or something. I had a friend from med school that has an Arizona license. She probably still has it. It was good for like literally 30 like 20 or 30 years, which is kind of scary because a lot can happen to someone's health in 20 or 30 years. Whenever I fill out a DMV form, there is an option. And I don't know if this is just a DMV in Oregon or if it's like this everywhere. I want to say it's like this at all DMVs. There's an option for me as the eye doctor to check a box that requires someone to be retested for their license in 6 months, 1 year, or 2 years. So patients with a potentially progressive eye problem, like macular degeneration or glaucoma, keratoconus, I don't know, certain things. If I feel like they are progressing at an alarming rate, I can designate that. Now, I normally don't do that. There's very few things that will make me feel like I need to do that, but it is an option. So I think as a physician, I can bypass that like normal license expiration dates. Now, the prescriptions, that's interesting. I have to look into that. I was not aware of laws or surrounding how long glasses prescriptions are valid. So anyway, a lot of interesting stuff. And the vision requirements for licensure is just something that we don't think about. The public doesn't think about until it affects them, right? You just go, you take your driver's test, you got your license, like you're good. There's a lot of people that think about all the people that either just have a license, that they have some kind of change in their vision. They've just never been to the eye doctor. There's a lot of that. And there was another comment about mandatory reporting. If a patient still has a valid license, but say they just come in for an eye appointment, they're a new patient, never seen them before, and I find that they had a stroke that took out the right side of their vision. If that stroke took out enough of their peripheral vision to where they don't qualify for a license, I am ethically responsible, maybe legally too, I'm not sure, but ethically sure. Like I definitely would feel like I need to do this. I need to have a conversation with that person and if I am, and basically tell them they can't drive. It's always a difficult conversation. And if we come to an understanding that they will not drive, and I feel like that's actually what's going on, what's going to happen, and I talk with the family and everything, I don't I don't feel like as long as I do my due diligence to make sure that person and document it appropriately, that this person said they will not drive and all this stuff, I don't have to like report them to the state. But if I don't have, and there have been a couple times when I don't have that kind of productive conversation with a patient, or they're really fighting it, they don't believe me, or they want a second opinion, I'm happy to have someone get a second opinion. Second opinion is always great. But there have been one or two times where I have had to like send a report into the DMV, like this individual does not meet the vision requirements for driving. And because it's a public health issue, like you don't want this person who could maybe not see a pedestrian crossing in front of them, or just any cars off to one side or the other. Like it is dangerous for people, especially when you live in a city. And so we take this very seriously in ophthalmology, as we should, right? Okay, let's take one more break, and then I have a topic to discuss. Okay, two more things. Let's see. People were asking about what my favorite Halloween decorations were. Oh, so many good. You guys did a great job with the comments on this most recent. This is the episode, Can You Believe These States Driving Vision Requirements? But I talked about Halloween. There are a lot of really good comments. So I appreciate you guys coming with those. So I apologize if I don't get the names on some of these comments, but you know who you are. So somebody asked what my favorite Halloween eyeball decorations were. I love it when people decorate pumpkins as eyeballs, because pumpkins, they kind of have an eyeball look to them. I like painting the white, and I've done that before as well. It's great. I once made a pumpkin that was an open globe because there was a knife in it. And the whole thing was, and there was like the pumpkin guts coming out, like the vitreous, very elaborate, that would only be impressive probably to an ophthalmologist. So I love doing pumpkin eyeball things. Obviously inflatable eyes. Like I talked about this last time. Love the inflatable eyeballs. They're not very sturdy though. So what I think would be great would be if I can have like a big giant, although I hate styrofoam with a passion, because once you have it, it's like it feels like you're just destroying the environment, just trying to get rid of styrofoam. But big styrofoam eyeballs, because they would be a little sturdier. They'd last through an entire Halloween. The inflatables, they get picked up by the wind if you don't tie them down right, and you can get punctured. And so I'm always looking for easier ways to have eyeballs. If you guys have ideas, crafts, things that ways for me to get big giant ass eyeballs on my house, in my yard, in my trees, give me your ideas. And it's okay if it's like a do-it-yourself thing. I really, you don't understand how obsessed I am with filling my property with as many eyeballs as I can on Halloween. It's very important. It's very important. Okay. So anyway, yeah, the eyeballs, any kind of eyeball is great. The pumpkin ones are awesome. If you guys have pumpkins, show me your pumpkin eyeballs. I love seeing those. Okay. Oh, okay. And this is the topic we're going to talk about, because I mentioned in passing, I mentioned endophthalmitis, and at Dan Yvonne 91 said, well, gosh, now I want to hear about endophthalmitis. In parentheses, unless you already went over it in an episode and I'm forgetting. You know what, Dan? I don't even know if I went over it before. There was a comment to that comment that said, no, I haven't. So I'm going to trust you guys and say that I have never done endophthalmitis, which is surprising because I did a whole thing right at the beginning of all the PANTS patients. So if you go back to the beginning, I talk about all the PANTS patients, angle closure glaucoma, the extraocular muscle entrapment, chemical injuries, what else? Giant cell arteritis, all the things. So let's talk about endophthalmitis, because endophthalmitis is the pants patient of all pants patients. It's such a pants patient, you guys, that I call it a no pants patient. I am not even bothering with pants when a patient with endophthalmitis comes in. I am getting out of bed. Not that I walk around my house with no pants on all the time. Like, I generally have pants, okay? But maybe I'm in a state, I just got out of the shower. Maybe I just don't have the pants on yet. And I get the page, it's endophthalmitis. I'm coming in. Everyone's just going to have to deal with the consequences, as will I, which will probably be jail. But I'm coming in because endophthalmitis, seconds, minutes count. Kind of like the other one that's probably also a no pants patient would be, to a slightly lesser extent, would be a retrobulbar hemorrhage requiring a lateral canthotomy. The reason I hedge on that one is because typically that's like you can't even wait for me to get in without my pants on. The emergency physician has to do it. No time. There's no time for me to get there. Endophthalmitis, like, it's fine. Like, just tell me to come in. I'll come in right away. You don't have to do anything. In fact, endophthalmitis is one of the easiest things for an emergency physician to diagnose. Because once you see pus in the eyeball, that's it. That's the diagnosis. You have it. Now, it might just be a uveitis, but you don't know. And it's not that important to be able to tell the difference. The easiest way to tell the difference, honestly, though, would be history of trauma or recent surgery. That's why every patient that comes into the emergency department, I tell this to emergency audiences, just get in the habit. Any recent eye trauma, which is probably going to be obvious, or any recent eye surgery within the past month. Ask those questions. And so recent eye surgery, pus in the eye, that is a single neuron arc to endophthalmitis. Call ophthalmology. You're done. You don't even have to check vision. You don't even have to check pressure. Like, if your ophthalmologist on call for some reason asks you to do it, great. But I'm already on my way, remember? And I'm just Winnie the Poohing it all the way to the emergency department. So that's the one takeaway from endophthalmitis. Okay, so what exactly is this disease? Maybe I should have started with that. What exactly is endophthalmitis? So it's infection inside the eye. It's a purulent inflammation of the intraocular fluid in the vitreous, the aqueous, the whole eye, and it's usually due to infection. Now, there's a couple different ways that this happens. And the most common ways is post-operative, acute post-operative endophthalmitis. That's going to be the vast majority of your endophthalmitis cases. It's the greatest fear for ophthalmologists. That's like the worst complication that you can get, because visual prognosis is generally quite poor. It's bad when you get an infection in the eye. So there's a big study, the endophthalmitis vitrectomy study, that looked at the best way to treat this. And it depends on how poor the vision is. If the vision is like hand motion or worse, so maybe the patient only sees like light perception, then they need surgery in addition. So basically surgery to go into the back of the eye and just remove all that infected fluid. And then you also put antibiotic into the back of the eye. If the vision's a little bit better, the patients, can see some hand movement, count fingers. Maybe they can see something on the chart. Unlikely, but maybe they can. Then you can treat them a little bit more conservatively with just intravitreal injection of antibiotics. So the typical things to start with, ceftazidime and vancomycin. Like, those are the two that covers the vast majority of your gram positives and your gram negatives. Gram positive is much more common of an organism. Often for post-op endophthalmitis, it's going to be staph epi. Very rarely, I think 90+% of the pathogens that cause endophthalmitis are going to be gram positives. If you get a gram negative in your eye, it's game over. Like it's that chances of maintaining useful vision in that eye are very, very low. And it doesn't happen very often, but it can in cases, typically that's going to be less common in a post-operative endophthalmitis, but trauma, you can get some gram negatives, still more common to have gram positive, but it can happen. And the pus in the eye is the thing on exam that you're looking for. All right. First of all, the patient's going to be in tremendous pain, very painful eye. And then you look at the cornea. So most people know what a hyphema is because we have fancy, weird terms for everything in ophthalmology. A hyphema is blood that's settled into the kind of the bottom part of the anterior chamber. So if you look at someone's cornea, the blood will kind of pool down at the bottom of the cornea. It's actually behind the cornea inside the anterior chamber. And imagine, though, that it's not red blood, it's white pus. That is called a hypopion. We have a fancier term than pus in the eye. Hypopion. Hypo. Hypopyon. One of the most ridiculous, top 10 most ridiculous words that we have. But we call it a hypopion. And then, and so that's a clear sign, especially with the history of surgery, that you have an infection. So we talked about, the diagnosis is easy. All right. We know what that is. I'll get my retina colleagues involved usually with these because often there's a retinal detachment. Sometimes there's a retinal detachment involved as well. Certainly if the patient needs surgery or those injections in the back of the eye, my retina specialist colleagues, they do a lot of that kind of stuff. I can do injections. I have done them. Surgery, no. That's under the purview of the retina specialist, the retina vitreous specialist, that they'll do that. So they'll take care of that. So it's a team approach to these endophthalmitis cases. Whenever we inject with antibiotic into the back of the eye, we'll also take a sample at the same time. So we'll tap, so we'll remove some of the vitreous fluid and then inject those antibiotics, which also helps with keeping the pressure down in the eye. Because if you just inject a bunch of antibiotic fluid, you're going to raise the pressure, right? Because the eye is like a balloon. You can inject a bunch of air, a bunch of stuff, a bunch of fluid. It's going to raise the pressure inside the balloon. So you got to take a little bit that helps keep the pressure down. And then we send that off to the lab for culture. That's what it is, culture. Now, there's different types of endophthalmitis. You can have like a chronic post-operative endophthalmitis that comes up over the course of weeks. Sometimes you can have a candida endophthalmitis that usually comes on a little bit more slowly. That's a whole different topic in and of itself. Often those can be endogenous, and so we get those inpatient consults from infectious disease, my wonderful infectious disease colleagues. Sometimes they'll consult us to take a look and see if there's any sign of a candida inside the eye. That's a big topic, and that's actually a hot topic, so maybe I'll save that for next time. But it's in general, it's just it's a difficult thing to treat, a difficult conversation. It's horrible for the patient. Now, the chances of having a post-operative endophthalmitis with cataract surgery is less. Now it's like less than one. Got to be less than 1 in 10,000. It's extraordinarily rare. And the reason for that is because of the advances we've had with cataract surgery to decrease the risk of infection. So at the end of the case, now we put antibiotic inside the eye at the end of the case, which greatly reduces the risk of infection. Sometimes we'll even give topical antibiotic. Sometimes we do both. Also, our incision size has gotten a lot smaller. We're much better at making these self-sealing incisions with cataract surgery so that they don't need suture and they don't leak. A leaky wound is a fast track to getting an infection inside the eye. So we make sure the wound's not leaking. They're small incisions on the order of 2.5 millimeters, very, very small. And those things the antibiotic inside the eye, it's just really reduced the risk of infection. So it's very rare to have a case of endophthalmitis. Again, I am knocking on all the wood in my house and in the Pacific Northwest. And that's the lowdown. I think that's probably enough. We're about 40 minutes into this. I'm going to keep it short for you guys. That's probably all you need to know about endophthalmitis. It's a scary disease. Probably it's like nightmare inducing. Ophthalmology, we remember our endophthalmitis cases if we're unlucky enough to have one. And they don't go away because they're always very challenging, and often it's a post-operative complication, which just makes it horrible for the surgeon and the patient. And so I hope this never happens to you, but if you are someone that works in emergency medicine, or if you've had eye surgery, these infections typically come on about 3 to 5 days. That's the key window for when an acute infection, a blinding potentially infection develops. 3 to 5 days. And it's not just cataract surgery. It can be a vitrectomy, any kind of surgery where you're going inside the eye. Typically not LASIK, not PRK. That's not going inside the eye. You don't penetrate the eye with those surgeries. But vitrectomy, corneal transplants, cataract surgery, even intravitreal injections, having an injection inside the eye for macular degeneration, for diabetes, that increases your risk. That's a risk of infection. Anytime you go inside the eye, it's a risk of infection. Why it's always part of the consent form, the consent process. And so if you're a patient, you have those types of procedures, just keep that in mind. That's something we always tell our patients about, all right? Any pain or decrease in vision after cataract surgery, after any kind of surgery, you let us know. And if you're working in emergency medicine or even in inpatient medicine, you see pus in the eye, call us day or night. That's it for Knock Knock Eye for today, folks. Let me know your thoughts. All right, give me your questions. Go comment on our YouTube channel at Glaucomfleckens. I want to see those comments. They help me. They provide us the ability to have these wonderful, rich discussions. And by discussions, I mean a conversation that I have by myself. It's important. So leave a comment. Let me know what you thought. And also, if I screwed anything up, sometimes I make mistakes when I talk. I'd love to see all that feedback. Thank you to my producers, Aaron Corney, Rob Goldman, and Shanti Brook. Knock Knock Eye is a human content production. Take care, everyone. Hey, here's to 39, all my fellow 39-year-olds out there. All right. I'll see you guys next week.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.